Now, Mrs. White's bone didn't become pathological by accident. There were a series of endocrine events and other events that led towards her bone lacking density and lacking strength. So let's look at the endocrine regulators of bone homeostasis. The first is calcitonin. Calcitonin is secreted by the parafollicular cells of the thyroid gland, and you can see those cells here, these kind of clear cells between the thyroid follicles that you can see there. It's released in response to high blood calcium. It inhibits osteoclast activity and lengthens the lifespan of osteoblasts. This means that the osteoblasts are going to have free rein to deposit this calcium along the bone matrix and mineralize that matrix, thereby using up that calcium. So in doing so, it's going to decrease the blood calcium concentrations. Parathyroid hormone. So this is secreted from the originally named parathyroid gland. And you can see the histological image of the parathyroid gland here. And this is released in opposite conditions to how calcitonin is released. It's released in response to low blood calcium. Now, in order to increase blood calcium, it's going to increase bone resorption. If you can resorb bone, you can resorb the hydroxyapatite, and therefore you can absorb the calcium that has been within that hydroxyapatite back into the blood. But if it's just in the blood, of course, we're going to urinate calcium out. It's going to be lost. So what we need to do in concert with increasing bone resorption is increasing kidney reabsorption of calcium at the proximal and distal tubular level. Now, the other effect that parathyroid hormone has is it increases tubular excretion of phosphate, inorganic phosphate. The reason why we don't want calcium and phosphate existing in high levels concurrently in our blood is that they can crystallize. Now, the final effect of parathyroid hormone is it increases enzymatic conversion of vitamin D to its active form. So you can see that on this little diagram here. So we've got low calcium levels, parathyroid gland releases the parathyroid hormone, increases calcium reabsorption, increases inorganic phosphate excretion. So the overall effects are it increases calcium concentrations within the blood and decreases phosphate concentrations within the blood. The other thing it does is increases the action of this particular enzyme, and it catalyzes conversion of vitamin D3 to its active form. More on that later. What I want to talk about here is the action of parathyroid hormone at the bone level. Now, we said that it increased osteoclast activity. Now, how does it do that? Well, what you can see here is that the osteoclast precursor and the osteoclast itself, which we haven't talked about yet, has no parathyroid hormone receptor. But there is a parathyroid hormone receptor on the osteoblasts that you can see here. So that's the first thing we need to take note of. Now, the second thing we need to talk about is this little protein that's going to be expressed on the osteoblast, which is referred to as the rank ligand. Don't worry about what this stands for. Now, given half a chance, the rank ligand and its receptor, rank, would bind, and that would induce the osteoclast precursor to then differentiate into an osteoclast. But the osteoblast normally prevents this from occurring by synthesizing a protein named OPG that you can see there. And OPG stands for osteoprotegrin. And in normal states, what happens is that osteoprotegrin is going to bind to rankle, this rank ligand, and it's going to prevent the rank ligand from binding to rank, its receptor. Therefore, the osteoclast does not continue to differentiate, or as I should say, the osteoclast precursor doesn't differentiate into an osteoclast. Now, what happens is that in the presence of parathyroid hormone, that comes down and binds onto the parathyroid hormone receptor. And two things happens when this binds. The first is that osteoprotegrin is no longer synthesized. The second is that rankle, this ligand, is upregulated, so more of them get expressed. This means that the osteoclast precursor can now come and bind to rankle. Now, when this happens, this results in a differentiation of the osteoclast precursor into a full-blown, multinucleated, badass osteoclast. And when that happens, that is now ready to reabsorb bone here. And as it does, it's going to leach this calcium and the phosphate back into the blood. Okay, so this is the mechanism by which parathyroid hormone here increases calcium blood concentration. So, how does it do this? In one statement, parathyroid hormone increases the number and activity of osteoclasts. And when we're talking about increasing the number of osteoclasts, the name for this is osteoclastogenesis. Cool. Let's talk about sex hormones, estrogen and testosterone. Well, estrogen is obviously secreted by the ovaries, testosterone by the testis, and both of them increase bone density. Now, estrogen has this curious effect of closing epiphyseal plates. Now, testosterone arguably does too, but this is much more of a pronounced effect in estrogen. So, because obviously females have high levels of estrogen, their physes close earlier, and this is one of the reasons why women are shorter in general than men. Now, both estrogen and testosterone decline in older age. So estrogen will decline in postmenopausal women and testosterone will decline in older men, the so-called andropause. Cool. Now I want to quickly look, because Mrs. White is obviously on the slightly older age spectrum, I want to look at what happens when our bodies don't have estrogen, and then I want to look at what happens when the body does have estrogen. So let's have a look at what happens without estrogen in the bone. So just reminding you, down here is our bone, our shoddily drawn bone. Now what happens is we've got several cytokines, so interleukin 1, interleukin 6, and tumor necrosis factor here. And without estrogen, they're going to bind to the osteoclast precursor, and it's going to increase osteoclastogenesis. So that's going to produce osteoclast. Now, simultaneously with this, cytokines, interleukin 1, and tumor necrosis factor are going to bind to the osteoclast, and they're going to increase osteoclast activity. Okay, so the kind of overall effect of this is that we're going to get bone resorption. Now let's look what happens to this process in the presence of estrogen. So here's our estrogen in the blood vessel, and it's going to diffuse out of the blood vessel, and what's this? We're going to get inhibition of these interleukins and also inhibition of the tumor necrosis factor. Now what this means is that IL-1 and IL-6 can't bind to the osteoclast precursor, and it won't differentiate into an osteoclast. In addition, the IL-1 and TNF can't bind onto this osteoclast, so it can't increase the activity of the osteoclast. So estrogen inhibits osteoclastogenesis. It also inhibits osteoclast activity. The overall effect of this is that the osteoblasts are left just to mineralize that matrix without the osteoclast interfering and constantly reabsorbing bone. So if you don't have estrogen, these osteoclasts are effectively unregulated and they have a high rate of resorbing bone, which is going to decrease bone mass, of course. Right. Growth hormone, secreted by the anterior pituitary, and it stimulates longitudinal bone growth, both directly by growth hormone binding onto bone cells, and also indirectly through this hormone, insulin-like growth factor 1. Glucocorticoids. Now this is really interesting. So it's secreted from the adrenal cortex normally, and the most important glucocorticoid is cortisol in the human, and that's the glucocorticoid that is secreted in the highest concentration in the human, although there are two others. And it's important in modulating stress responses, so it is released normally in the body. But the effect of glucocorticoids is to inhibit bone matrix mineralization and induce apoptosis of osteoblasts. So if you inhibit mineralization, then you're going to decrease the strength within bone. If you inhibit apoptosis of osteoblasts, you're going to have fewer osteoblastic cells to increase the strength of bone. Now there's also an interesting effect where it inhibits osteopenia. protegrin. If you inhibit OPG, that means that the rankle, the ligand, and rank, the receptor, are going to be able to bind together, as we demonstrated before, and that's going to increase osteoclast number and activity. So persistent high levels of glucocorticoids through these mechanisms can result in osteoporosis. Now, why would we have persistent high levels? Well, one could argue, well, maybe that person's just been stressed for a long duration of their life. Is this going to result in osteoporosis? Well, the data's not clear on that yet. But what can cause persistent high levels is administration of glucocorticoids for medical reasons. So someone might have corticosteroids for long-term asthma control, or they might be administered corticosteroids for control of an arthropathy, an inflammatory arthropathy, or another autoimmune disease. And if you do that, then chances are, after many, many years of persistently high levels of glucocorticoids being given to a patient, these patients might become osteoporotic. So it's definitely something for you to keep in mind if you see a patient who's been on long-term corticosteroid use. Vitamin D. Vitamin D is not really a vitamin. Why? Well, vitamins are kind of defined as a substance that is essential to an organism for normal functioning and is obtained through the diet. Now, vitamin D is not obtained in large amounts through the diet. The large amount of vitamin D comes through the interaction of UV light, UVB light, with the skin, and so it can be produced in that way. So because it's synthesized largely through sunlight exposure, it's not really a vitamin, although we can have small amounts in dietary exposure. What's the actions of vitamin D? Well, it increases availability of calcium and phosphate in the blood through increased intestinal absorption of these ions. Of course, if you've got more calcium and more phosphate, then you can use these ions to increase matrix mineralization, which increases the strength of bone. Now, if you have vitamin D deficiency, of course, you have less availability of calcium and phosphate, and this can result in rickets in children and osteomalacia in adults. And malacia means bone softening. Now let's just have a quick look at how this actually happens. So here's UVB light, comes down, and it causes cholesterol to form this vitamin D3, goes through the liver where it picks up a hydroxide group, then it goes into the kidney. Now, we said before that parathyroid hormone secretion is going to catalyze the conversion of this inactive vitamin D to this active form, which is referred to as dihydroxycholecalciferol. Now, this is going to go to the intestine where it's going to increase calcium reabsorption and is going to increase calcium concentration within the plasma. That calcium can then go to be sort of warehoused in bone, and in doing so, it increases bone density.